Hi, my name is Onyekachi Ibe. My presentation is on the case study of ectopic pregnancy, and my presentation will be answering the following questions. How can fertilization occur outside the oviduct? What kinds of hormonal complications would I expect in this situation? What is a life-threatening why is ectopic pregnancy a life-threatening condition? How is it treated, and what are the possible consequences of that treatment? Okay. So, what is an ectopic pregnancy? Ectopic pregnancy is a condition where a fertilized egg implants outside the uterine cavity, most commonly in the fallopian tube. Less frequently, implantation may occur in the cervix, ovary, or even the abdominal cavity. It affects about 1 to 2% of pregnancies and cannot progress to a viable birth. Because these locations aren't suited to support placental growth or embryo development, ectopic pregnancies are considered both non-viable and dangerous. Under normal conditions, the sperm meets the egg in the ampulla of the fallopian tube, but in ectopic pregnancy, abnormalities can interfere with this process. Scarring from prior infections, endometriosis, or surgeries can disrupt ciliary movement or block the egg's journey to the uterus. Sometimes, sperm or zygotes may migrate abnormally through the peritoneal cavity. In rare cases, the fimbriae fail to collect the oocyte, allowing it to float freely and implant elsewhere. In an ectopic pregnancy, hormonal signaling is disrupted. The fertilized embryo still produces HCG, which can yield a positive pregnancy test. However, without uterine implantation, there is no proper feedback to maintain ideal progesterone levels. The couple's luteum is kept alive temporarily, but hormonal imbalance follows. These disrupted signals can confuse both the patient and provider and increase the risk of rupture due to unchecked growth. Why are ectopic pregnancies life-threatening? Ectopic pregnancy is life-threatening primarily because the implanted embryo grows in a space not designed to stretch, like the fallopian tube. As the embryo grows, it can cause rupture, leading to massive internal bleeding. Without rapid intervention, this can result in hemorrhagic shock and death. It is the most common cause of maternal mortality in the first trimester. Treatment options and their consequences. Treatment depends on the size and location of the ectopic pregnancy. In early cases, methotrexate may be given to stop cell division and allow the body to reabsorb the tissue. More advanced or ruptured cases require surgery, either removing the affected tube or repairing it, such as salpingectomy or salpinostomy. These surgeries, however, can affect future fertility and increase the risk of repeat ectopic pregnancies. The emotional toll is also significant, as this is often a wanted pregnancy that cannot continue. In summary, ectopic pregnancy is a serious and often life-threatening condition where a fertilized egg implants outside the uterus, most commonly in the fallopian tube. Although hormones like HCG are still produced, the environment cannot support healthy embryo development. If left untreated, the growing tissue can cause rupture and internal bleeding. leading to hemorrhagic shock. Treatment may involve medication like methotrexate or surgery, both of which can have long-term implications for fertility and emotional health. To help solidify what we've covered, I've prepared a short worksheet with both recall and clinical thinking questions. It covers the anatomy, hormones, risks, and management strategies involved in ectopic pregnancies. So my case study is a 29-year-old woman presents to the ER with sharp lower abdominal pain on her right side, light vaginal bleeding, and dizziness. Her pregnancy test is positive, but no intrauterine pregnancy is seen on ultrasound. The first question is, what's the likely diagnosis and why? I would say ectopic pregnancy based on the pain, bleeding, positive HCG, and no visible intrauterine gestation. Secondly, which hormone is likely present in her blood? I would say HCG. And third, why might her progesterone levels be insufficient? They could be insufficient because no uterine implantation, meaning no endometrial progesterone feedback loop. Why is this situation potentially fatal if left untreated? Risk of tubal rupture, hemorrhage, shock, which could lead to death. And what treatments might she be offered and what follow-up care is important? Methotrexate if stable, or surgical intervention, follow-up HCG monitoring, fertility counseling, and lots of psychological support. I've come to the end of my presentation. Thank you so much for listening. These are my citations. Thank you.